Welcome to Beyond the O.R. with Dr. Kevin Brenner. I'm a board-certified plastic surgeon in Beverly Hills. I want to take you beyond my world of plastic surgery, diving deep into exciting hot topics and delving even deeper into compelling characters that I've met along the way. We'll be talking with attorneys, actors, comedy writers, Navy SEALs, and many other fascinating and inspiring people with truly intriguing stories to share. So let's jump right in. Welcome back to Beyond the O.R. Today's show is all about you. I get asked questions all the time on Instagram and Facebook, TikTok about plastic surgery, this, that, and the other topic. So this time we came to you across all of our social platforms and asked you, the viewers, you, the listeners, you, the followers, what questions do you want answered, either about me, about plastic surgery, or anything really. So we're going to try to get to most of them today. Elizabeth, you have them.
I have them.
You have them teed up, right?
I do.
I think it's worth mentioning that even if you've been watching since last season, you know this show is not about plastic surgery necessarily, although I do like to throw in some tidbits every now and again. Most importantly, and this is the same thing I tell all my followers on Instagram and TikTok, is this is not a show about medical advice for anyone specifically. If you want specific medical advice, you got to come see me or your surgeon or your doctor privately, confidentially, to have a consultation and figure out what's going to work best for you. So with that, we're just going to talk generally about different issues in plastic surgery and kind of what I've seen and how we've handled it. So
here we go.
Take it away. Let's hear what the listeners have to say.
Thank you. First of all, congratulations.
Thank you.
On your
what now?
Your Hulu piece on Impact. Tell us a little bit about that piece with Black China and.
That was really, really, really a special piece. So yeah, we were ABC Nightline did a piece on explanting, kind of the rise in popularity of explanting. And then they did an extended version on their streaming platform on Hulu called Impact. That's the name of the series.
Yeah.
All about explanting and did kind of feature the backstory on Black China, Cara Crawley from The Bachelorette, as well as some other celebrities, Chrissy Teigen, who have all come out publicly to announce that for whatever reason they've decided to remove their implants and go through that process. The show was great. So the producers at ABC came to me and wanted to follow a patient through the process, coming in, pre-op, day of surgery, a little bit of the surgery itself, and then follow-up. So yeah, I'm really happy about it. I'm just happy that this topic is finally starting to get the attention that it deserves.
Yeah, I agree. It's a great piece, and also, you know, as we're seeing trending right now is more of a natural look. Anyway, like people have in that report, in that piece that you did, it shows how augmentation has gone down and explantation from the year 2000 to now has escalated.
It has across the board, across the country. I mean, there's no question if you look at like the statistics across the country that is true. Breast augmentation is still pretty. It's still pretty popular. I don't think it's going away. My intent is not to make it go away. My intent is to bring awareness to the fact that not everyone does well with them, right? Some people really do have a reaction, and there's a lot of women suffering from any one of 40 or 50 symptoms that may be super mild and may be debilitating. And you know, because you've kind of seen us kind of going through this process as it's become more popular. But
I myself went through the process.
Right. And it's it has gained momentum on a really rapid pace.
So let's start there. Let's start with the BII questions, you know, that people, and I have to put on my glasses because I can't see. So here's a question. Can you do fat transfer and a lift after explant?
So This is a question I answer just about every day when I'm seeing patients. When patients come in for explant, we're taking out the implant, we're taking out the surrounding scar tissue called a capsule, and then figuring out what additional procedures to try to restore, rejuvenate the breast. Many women don't realize until they've been through it that simply having an implant placed, whether it was a year ago, 10 years ago, or 30 years ago, that having that in your body for a period of time has an effect on your body's tissues. There's no question about it. It stretches out the skin, it stretches out the breast tissue. For some women, especially when the implant's placed below the muscle, just the everyday action of you getting up, doing push-ups, taking a shower, brushing your teeth, opening a door, your muscles pushing down that implant, and chronically over a period of time, it will put pressure on the rib cage, and sometimes women will have scalloped rib cages just from the pressure. You know, your ribs
Wow.
are living, breathing tissue, and they will respond to pressure, just like a bone would respond to pressure.
So it's
So too will the
basically you're
cartilage.
concaving, right? Like a little bit.
Sometimes on the chest wall.
Wow.
So you know, my job is not only to get rid of the implant for these patients, but then to restore the breast. Most of the time that involves doing a breast lift, right? Because the skin's been stretched out. So there's more skin on the breast than there was before they had their breast implant put in.
Right.
Skin is amazingly elastic, and so it will stretch and recruit. And so part of the breast lift is getting rid of the extra skin. The other part is kind of moving the nipple up for people who've had aging of the breast or sliding of the breast off of the implant, which we see all the time. And then, you know, there's another technical component to it, which is when I'm doing an explant, I have much better what we call exposure. In other words, I can see a lot more through a larger incision that I would be using for a breast lift than I would if I wasn't doing a breast lift through a smaller incision. So it can be done both ways. It's just technically a little bit easier. And if it's easier for me, it's usually a little bit safer because you can see everything much more clearly.
And do you recommend the fat transfer in that same procedure of explanting and lift?
That's a great question, and I'm glad they asked. But so I do a lot of fat transfer now to restore volume. The intent is not to restore the volume to what they had with an implant, because you're probably not going to have, most people are not going to have enough fat to do that.
Right.
Because not only do you have to have the fat to give, you have to have somewhere to put that fat, right? We don't just take out an implant and replace it with fat, because the fat would all die, liquefy, harden. It has to actually be specifically placed into the tissue, so your body grows new blood vessels into the fat so that it stays permanently.
Okay. So would you do that the same day that you would do it, or would you recommend waiting to do the fat transfer?
I have done fat transfer at the same time as an explant in a few cases, but I've found that if you wait and do it in a staged or delayed fashion, that the percent of fat that stays long-term is a lot higher. So I now prefer to wait. Not everyone is necessarily willing to wait. So there are some occasions where I'll just take everything out and do a little bit of fat transfer to give them a little volume right off the bat. I personally, I know some surgeons will, I personally I'm not really willing to do fat transfer at the same time that I'm doing an explant and a lift, simply because I think it increases the risk of complications too much. Most specifically, you know, when you're doing a breast lift, you're rearranging the tissue, you're cutting through some arteries and veins, and you're maintaining some arteries and veins. And it's very easy, if you have only one artery and vein going to your nipple, that may be adequate, but if you then take fat and inject it all around it and put pressure on that, you can knock off the blood supply and potentially lose tissue that way, or lose skin, lose the nipple. So I'm not a fan of doing it at the same time. That's probably the biggest reason. The other thing is that I think that a lot of patients who really suffer from BII, they're just in this sort of chronic inflammatory state. And if you can give them an opportunity to kind of recover from the explant, get rid of some of that inflammation. A lot of women have like fluid retention, and so the tissues are swollen. So if you can give them an opportunity to kind of get back to what their normal pre-augmentation homeostasis is. I think the fat grafting does better.
Well, yeah, I would personally myself, I would rather wait because from the time that I explanted, my breasts size and shape and all of that changes throughout the month. So you don't really, like, I'm glad I waited.
In particular, during the first year.
Yeah, exactly. Okay, well, next question we have here is, do you do removal of implant with fat transfer with teardrop? What is teardrop? I don't understand.
I'm not sure. I know you didn't write this, but well, teardrop is basically a shaped implant. I think that's what they're referring to.
Okay.
So you can some of the implant companies will make most of the implants that we see today are what we call round implants. So it's perfectly round, and they come in different profiles.
Right.
In terms of what the projection is from the bottom of the implant to the top of the implant. Obviously, different volumes. That also, those combinations confer different dimensions, so different widths and whatnot.
Okay.
So most implants are round. I don't have an implant here to kind of show you the difference, but some companies make what are called anatomic implants, and those are teardrop shaped, if you will. So if you hold it flat on a table, it's somewhat round, but if you hold it up and look at it, in particular from sideways, you'll see that there's a little bit of
a slope?
A slope to the implant.
Okay.
So that the upper pole of that implant has relatively less volume and the lower pole has relatively more volume. So you're going to get more projection, which it confers in women who are candidates for an anatomic implant, it confers a little bit more of a natural slope.
Right.
And a lot of surgeons like using those because, especially for women who don't have a lot of breast tissue to begin with, they like using it because it just gives a little bit more natural look than that kind of fake full fullness that some people
want. Well, you see, I learned something today.
So yeah, you can do it, but again, I still don't like to do fat transfer at the same time as explanting.
Okay. Next question: how long is the recovery after implants have come out after explants?
So as a rule, the recovery is kind of dictated by a couple things. Number one is taking out the capsules. So I tell everyone this, taking out the capsules hurts. When the implant's below the muscle, the capsule's below the muscle. So the top or the front of the capsule, the anterior surface, is on the breast and on the pectoralis muscle, that's our big chest muscle. And then the back of it is on the rib cage and the pec minor muscle, which is the second biggest chest muscle. And so separating that out with a electrocautery device, there's thermal energy and there's also just some surgical trauma to it, and it hurts. And anytime you touch a muscle, if you've
sprained a muscle
or if you haven't been in the gym for a while and you go back, you're like, I'm going to do arm day, and you're like, the next day your arms are killing you. That's just lactic acid being released into the muscle just from the muscle being touched and worked or overworked. So it hurts. And even though I do use almost routinely now a medication that's a long-acting local anesthetic called Exparel, I have no vested interest in the company, but I like the product because it provides about 3 days of local
that was a
anesthesia.
lifesaver for me.
Yeah, it's super helpful. So you have that, and then when the implant's below the muscle, I do like to repair the muscle whenever possible. It's not always possible, but in particular when I do a lift, I will try to take that tissue that I'm lifting and tack it to the muscle so that the muscle doesn't window shade up over time and get scarred and look weird. And so for that, I want patients to really take it easy, usually for about 6 weeks after surgery.
Okay.
And by that, I don't mean lay in bed like a banana slug. I mean,
don't work out.
No, you can, I like people to get up and move around, do some light cardio, but I don't want people doing like Pilates where they're using their arms a lot, or playing tennis, or lifting weights, or push-ups, pull-ups, and any of that stuff. You got to really wait 6 weeks, because not only do I not want them to bleed after surgery, I don't want the muscle repair to fail. I don't want the incisions to open. So I'm a little too conservative, but I'd rather not have an issue with any of my patients.
Okay, so 6 weeks.
rough, give or take.
Yeah, okay. All right. This is a long one. So here we go.
We have time for
Yeah. Do you perform microsurgeries, and can you do a breast reduction on a DIEP flap?
Okay, so that is, let me explain. 'Cause
Yeah.
most people
Explain,
have,
Lucy.
most people have no idea what. So let's sort of clarify. A lot of times people ask questions thinking that one thing's different or similar to the other. So a breast reduction, just so we're clear, a breast reduction means actually removing breast tissue, and that involves also lifting the tissue. So removing not only skin like I would do in a breast lift, but removing breast tissue. And that's for women who naturally or over the course of their lives have developed breasts that are just way too big for their body and their frame, causing neck, back pain, rashes, and things like that. So that's oftentimes a functional procedure because we're removing between 500 and 1,000 grams of tissue, on each side.
Okay.
Now, this question is referring really more to patients who've had breast cancer and mastectomy. And what a DIEP flap is a deep inferior epigastric perforator flap. So a lot of people have heard of microsurgery. When I was training at UC Irvine, when we were doing breast reconstruction, we almost exclusively did microsurgery. We call them free flaps because you're taking the tissue, dissecting out the artery and the vein, clamping it, taking it from where it comes, where it originally was from, and then putting it into where it needs to go.
Okay.
Hooking up the vein under a microscope, hooking up the artery under a microscope. And then that tissue is your tissue. So it's not like a transplant or a graft or anything like that.
Right.
It's your own tissue. It's just been moved from point A to point B, and you maintain the blood supply. So it lives off of the blood supply from somewhere else on your body.
Okay. Oh.
Yeah. So that's kind of the most basic sense of what microsurgery is. Now, in the breast reconstruction, the history of breast reconstruction, we as plastic surgeons have gone from doing what's called a tram flap, which is an acronym for transverse rectus abdominis myo muscle cutaneous flap. So what that means is you're taking the tissue akin to like a tummy tuck, taking that tissue with the underlying muscle and therefore with the artery and veins that go through the muscle to the skin. And you're taking that and originally what we would do was called a pedicled flap, where you take the tissue and then swing it up into the breast, tunnel it underneath. And so you're taking abdominal tissue and keeping it attached to its original blood supply, but separating all the other attachments. So it's like a peninsula, and then and sort of swinging it underneath.
That's crazy.
So it's crazy, but it works. But that has evolved with the evolution of operating microscopes. That has evolved to microsurgery, and therefore they look better. You can take less tissue. There's less disruption to the abdominal wall, because when you take the muscle from the abdominal wall, people get essentially a giant hernia and they can't really contract their stomach anymore.
Like an umbilical cord hernia, right?
No, I mean like
Okay.
six-pack abs.
Okay.
That's the rectus muscle.
Okay.
So if you can imagine, if you have only a 3-pack abs on one side and the other 3 cans went and they're up in your breast, you're going to lose that ability to contract because you don't have that muscle anymore.
Right. Okay.
So that's what's called a tram flap, and then that evolved into what's called a micro tram flap, where we could do that without taking the entirety of the muscle, just take a little bit of the muscle, and then that evolved to what's known as a muscle sparing tram flap, where you would just take a little bit of the muscle that was around the artery and vein to try to preserve more of the abdominal integrity. And then that has since evolved for the last 10, 15 years to what's known as a perforator flaps. A perforator is simply the arteries and veins that come from your rectus muscle up into the tissue. And so instead of taking the muscle, you're actually separating the muscle and taking it all the way back to its origin until you have enough length on that artery and vein that you can just take the skin and fat from the tissue with the artery and vein attached to it, and you don't need to take any muscle.
Oh,
So
wow.
that's what perforator flaps are. All right, so that's a very long-winded explanation for a short question, but read the question again now that we
You
have the
perform microsurgeries, and can you do a breast reduction
Right.
on a DIEP flap?
Okay. So no, I no longer perform microsurgery because it really requires a team and usually a tertiary care center and a university setting. It's very difficult to do it by yourself in private, not impossible, but difficult to do in private practice.
Okay.
Um, but by that, if someone has, let's say, an A cup on normally, and then they had a reconstruction on the other side with a DIEP flap, and the tissue was maybe more than an A cup, and then they want to come back and make it smaller to match it up, yes, you can go back and take that flap and kind of remove a little bit of the tissue to try to even it up with the other side.
Okay. Wow, you have
Lot-
very schooled followers
Yes.
that
Very
know their-
educated
Yes.
listeners and followers.
I say now the second part of this question is if BII is occurring on a lat flap
Okay.
with an implant and there is a DIEP flap on the other side,
This is a compound question.
yes, without an implant, so
Right.
like just one implant, right? Is there a way to remove the implant on the one side to make both sides symmetrical-ish?
Okay. So in this case, someone had reconstruction on one breast after a mastectomy with a perforator flap, a DIEP flap. And on the other side, had an implant placed as an augmentation to try to match up the size,
Right.
and subsequently develop BII. So they want to then take out the augmented implant, okay? In this particular situation,
Right.
instead of a DIEP flap, they're referring to what's called a latissimus dorsi flap, LD. And what that is, that's actually your back muscle. That's back here. We use that for breast reconstruction. So just like we were talking about a pedicled tram flap from your belly up to your breast, you can take your latissimus muscle, which is the big back muscle, which kind of lets you do this push up out of a chair.
Okay.
Take that with or without the skin overlying it, depending on how much tissue there is, and take that and tunnel it up through the armpit and into the breast. That's called the latissimus flap. Now those flaps are very hardy, very useful. They have their own blood supply, and it's pedicled, right? So it means that the original artery and vein are still attached.
Okay.
It's just you're taking it and moving it from point A back here to point B on the front of your chest, from back to front. They're very hardy flap, good blood flow. It's very useful, in particular for patients who've had problems with their breast after mastectomy, be it from radiation or infection or inflammation or what have you. Because oftentimes, especially with patients who've had radiation and then an implant reconstruction, it's not uncommon to get really bad scar tissue, to get infections, to get wound breakdown, capsular contracture, and things like that. So yes, you can go back, preserve the latissimus flap, and take out the implant. But the latissimus flap, the whole reason that there's an implant underneath the latissimus flap is because the latissimus flap doesn't have a lot of volume, whereas a DIEP or a tram flap has much more tissue to it. So you oftentimes don't need an implant with this, with some version of a tram flap, because there's a lot of women have a lot more tissue on their belly.
Right.
With a latissimus flap, there's usually less tissue. So a lot of surgeons will put an implant underneath it to add volume for symmetry purposes.
So can you remove the implant if that's what they have and
you
even
can't-
out the breast?
Yes, you
Okay.
can. You can, but there are sometimes extenuating circumstances.
Man, I am learning so much.
Lots of stuff.
The human body is
breast reconstruction.
insane. Oh my God!
It
Like
really is.
removing, it's not a whole muscle. Is it a piece of the muscles? The whole, how do you do this if you have that?
Well, you use your other muscles.
Wow, that's insane.
I mean, for people who do this professionally, I don't know who does that.
Oh, wow,
It's not a good option, but yeah.
Wow. Okay. For women who have had implants due to breast cancer, what do you recommend they do surgically after explant?
Right. So they had breast cancer, they had implant-based reconstruction, and sometime later developed BII or some other complication, and they just want to have the implants removed.
Correct.
So oddly enough, I just saw a patient very similar to this yesterday for consultation. Um, she was a lot more complicated, but did have breast cancer on one side and had an implant-based reconstruction on that side and had an augmentation on the other side to try to match up the sizes. She now has BII along with a host of other issues and wants them, or at least wants this one removed. For a patient who's had a mastectomy, those are perhaps the most challenging because there's not a lot that you can do locally with the tissue that's there, right? Because with a mastectomy, many people don't realize this, but you have a breast mound, and that's almost like a cone or a volcano, right? And that comes up to the nipple areola complex. And I mean, that's the majority of the breast. And then on top of that, you have skin with a thin layer of fat underneath the skin that's not technically breast tissue, but it's immediately adjacent. So when we talk about doing mastectomies or for cancer surgeons who do mastectomy flaps, you're separating the skin with a little bit of fat on there because that's where there's a little nourishing layer of small arteries to keep that skin alive.
Okay.
And then taking out the breast mound. So, depending on how much space there is, how big the breast was originally, and depending on what the person's BMI and their body habitus is, they're going to have a thicker or a thinner layer of fat there. If you don't have a lot of fat, there's not a lot to reconstruct locally. So a lot of women, and I see it online, are opting for what we call a flat, F-L-A-T, flat closure after mastectomy. That simply means taking off the breast and closing the skin and getting rid of any redundant skin and just literally keeping them flat on their chest wall, which is ironically how it used to be before we had reconstructive techniques evolved enough to build a breast.
Okay.
There's, if that's not an option, if that's not something that you're interested in, and a lot of women are not, then you as a patient really need to look at alternative methods for reconstruction with your own tissue, like we talked about before, latissimus flap or DIEP flap.
Okay. All right. Man, I am learning so much. These are great questions. Do you ever post before and after pics?
All the time.
Okay.
So we have them on. Yeah, people ask me and they ask for more. I mean, I do it. I also do it with patient's permission. So not everybody is willing to have their breasts or face, on the website,
Right.
on Instagram. But yeah, we do. I mean, we try to keep the Instagram varied. So yes, occasionally we'll have before and afters, and then we'll have videos, and then we'll do other things.
And then your website has before.
There's
and
an
after.
entire gallery of before and after photos going back 15 years. I mean, I even have breast augmentation photos from when I was doing that, because, even though I did them a long time ago, but they're still up there. I mean, there's a lot of lifts, reductions, tummy tucks.
Are you still doing
facelifts.
augmentations?
Augmentations? No, I stopped putting in implants last year.
Congratulations. No, I mean, that's great with BII.
I don't know if
if
it's a congratulations for me, but it was just something that I felt that I needed to do.
Why?
Just seeing too many problems, too many complications, and I couldn't justify putting them in anymore. When you see people day in and day out debilitated, and then suddenly you take them out and their personality's back, a lot of their medical issues are either resolving or improving. It has to, I mean, at least for me, it made me stop and say, what am I doing? Because for a long time, I didn't really necessarily believe that the implants themselves were bad. I just thought that there was a subset of people who just didn't do well with them, which
Right.
is probably still true.
Right.
I mean, if you just look at the absolute numbers, I mean, there are women that with breast implants who are totally fine with no medical problems, and that's great. I'm not wishing.
Yeah,
I'm
lucky them.
not wishing it, but proportionally, there's a lot more patients with breast implants than who've been explanted. So,
Well, when I met you, I was a shell of the person I am now, you know, and after,
what would our show have been like if
yeah, there would have been no show.
you would have been like in the corner curled up?
Okay, so unrelated to BII,
Yes.
can you just repair a UH, which a UH is an umbilical hernia?
Bingo. Look
See,
at you.
like working
You're
with you,
you're
I am learning.
It's like you're getting a medical education.
I know.
No.
Thank you, Dr. Brenner.
We're gonna do physiology next week.
I just can't see blood. I'll pass out. Like, so can you do it without a tummy tuck? Can you repair a UH, an umbilical hernia,
Yes.
without a tummy tuck?
Yes. So fixing those
Without a tummy tuck, you
if
can
they're
do it?
tiny, you know, a lot of them don't need to be fixed, but when they get big enough, they should be fixed because you don't want to have a complication. A lot of times, a lot of hernia surgeons, general surgeons who do hernia repairs will fix the bigger ones with mesh. I've just, since I do plastic surgery and I don't really do general surgery anymore, I mean, some hernias are sort of in our purvey. I'll usually just do what's called a primary repair where you just sew them together. You know, I do them very commonly during a tummy tuck, but yes, they can be repaired without a tummy tuck. That was a very long-winded explanation for a short question.
So yes, okay. Can you remove a benign, you know, I can't say this, fibroadenoma?
Fibroadenoma.
Fibroadenoma during a breast reduction or breast lift. So what is a benign fibro?
So a lot of women, especially younger women, their breasts are very fibrous, and some people will have what are called fibroadenomatous breasts. All those are benign fibrous tumors of the breast.
Okay.
And if they're having another procedure, want it taken out. So the answer is if I'm doing a breast lift or a reduction, if that fibroadenoma happens to be in an area that's accessible easily as part of my dissection, yes, you can take it out. I mean, you can take it out anyway, but
you could do it during the procedure.
Before I can do it during the procedure, as long as it's not going to interfere with the blood flow to the rest of the tissue.
Okay, all right, and then we have to go quickly here because we have to wrap up. How did you meet your podcast producer?
Oh my God.
And form a working relationship?
Okay, I'll forgo the jokes.
Okay. No, do the jokes.
So you came to me as a patient originally, right?
Right.
You had BII.
BII.
Right? You had pancreatitis specifically.
Yes.
Was the big thing, right? Amongst other things.
Yes.
And then after you were explanted, you were at the time on your podcast, Left Unsupervised.
Yes.
Right? And then you invited me onto your podcast, and I said, why do I need to go on a podcast? And you're like, just come on, it'll be fun. I'm like,
yeah, we're talking about my BII journey.
So we did that, and it was a good show. It was actually a great episode, right?
Yeah.
And then you came to me after that and said, you need to have your own podcast. And I said, no, I don't. Right?
Right.
And you said, no, it's gonna be good. I'm like, no. I said, the last thing that we need is another plastic surgery podcast.
So I don't need any more things to do.
And, and I have to do it on the
weekends.
on the Sabbath.
Right.
So, and I said, okay. Finally, you wore me down. I said, if we're going to do this, I'll do it, but it can't be like a plastic surgery podcast. I want it to be more interesting than that, because more interesting to me.
Right.
I know a lot of our viewers love plastic surgery, but it's not a plastic. But we get some
bits
of plastic surgery, how it applies to other things.
Well, that's a segue to the next question is, what do you enjoy doing on your free time?
That was not a segue to the next question.
Yeah, it was. It really was.
That really had nothing to do with the fun. What do I do? That had nothing to do with it.
No, it is, because at least you wanted to start
I'm doing a podcast in my free time.
No, you wanted to start the podcast because you wanted to do things of other interest. You have so many people that you know that are so interesting. So that was the reason why you wanted to start a podcast, not to just speak about plastic surgery.
That is correct.
So the segue to that
You don't
is,
even need me here for this. Okay. So what do I do? I'm a family guy, so I like spending time with my girls and my wife, and some other family. I'm not going to name names because if I miss somebody, they're going to be upset.
You're going to be in trouble.
I just picked up scuba diving, so last year I've been wanting to do it my whole life.
Certified?
Got certified, PADI certified scuba diving for open water dive. So that I enjoy doing, although it's a bit of a chore. So it tends to be something that I can only do when I'm on vacation, somewhere on the coast. But I really love. It's just really serene being down there. I'm a little bit of a gun nut, so I love collecting guns, but also going to the range and shooting guns. And probably the thing I do the most of is cooking. So I think we.
I hear this all the time. I have yet to taste anything.
Well, you got to be invited over first.
Exactly. Yeah. That's my point.
This is getting awkward. So yeah, I love cooking, and during the week I just don't have the time to do it. But I do on the weekends. Saturdays and Sundays, I try to make dinner for the family whenever possible.
Okay, 2 things I want to hit on really quick because we are running out of time. Is you have a fake account that we want everybody to know about.
There's so many fake accounts.
But one in particular, they're using your picture on Instagram.
There's a lot of Instagram and on Facebook, and I don't understand why.
So unless,
but I have followers that will message me and say, "Oh my God, this person, you need to know about this. This person's been trying to contact me. I don't know if they're trying to get money or get them to send naked photos of them. I mean, I have no idea." But yeah, there's a lot of. There's a lot of creep, and it's. They're not. I don't think it's. They're like trying to steal my financial information or anything.
Well, I don't know. There's a guy named, I want to call him out, Owen George, that has your picture on it. So let's call him out, Owen George.
Do I look like Owen George?
No.
But there's several Owen George accounts, and they have followers, and
it's crazy.
It's insane, and I don't understand. I mean, this guy likes a lot of my posts, but he steals not only my headshots, photos from work, before and afters of patients, but like pictures of me with my kids, videos that I post on Instagram. I don't do a lot of my family on my business account just because that's what my private account is for.
So we just want to be
if
weary.
You know Owen George, maybe you can have him give me a call.
Yeah.
I don't know.
Just be aware that if you follow Dr. Brenner, that you are following the correct person, even though sometimes it might have his picture.
I only have one verified account. So.
Okay. All right. And one last question. I'm going to give you 2 options.
2 options.
Either health insurance, we're going to talk, or what is the difference between a full tummy tuck and a mini, but it has to be a condensed version?
That's going to be first, and then I'll talk about the health insurance. Health insurance could be an entire show, but briefly, there's a full spectrum of tummy tucks. All that means is taking out skin from the abdomen, tightening the muscle, and getting rid of the excess skin. Sometimes women don't need the muscle tightened. Sometimes they take out all the tissue and we have to tighten the muscle. A mini tummy tuck is really just taking out a little bit of tissue from the lower without tightening the muscle.
Okay.
And so the incisions tend to be shorter than on a full tummy tuck. But again, for anyone who wants a tummy tuck, the length of your incision is dependent on how much extra skin you have to be removed.
So the in layman's terms, like for listeners and me who doesn't know, a full tummy tuck is
you are a theoretic surgeon.
Yeah. Is a tightening of the muscle, where mini is removing like fat or tissue and no muscle tightening.
At the most basic level, yes.
Yeah,
there's
there's
some gray area in between.
Yeah. Okay, so I guess that's it. I think we got to maybe 2 other questions, but we don't have time. So that's it.
We're gonna have to do a whole show on health insurance because people ask me all the time why their stuff, can it be covered by insurance? Why it's not covered by insurance.
And then they get mad at you, but it has nothing to do with you.
They
It
get mad
has
at me,
to do
and
with the
I'm
insurance
more
company.
frustrated with the insurance companies than the patients because I'm the one that has to deal with them.
Okay. Well, thank you, Dr. Brenner, and you can wrap up your own show.
Oh my God. I have to do everything around here. Thank you guys for watching Beyond the O.R. Make sure to like, follow, and subscribe so you don't miss any of our amazing future episodes. We'll see you next time. Thanks so much for listening to Beyond the O.R. with Dr. Brenner. Make sure to subscribe, like, and follow so you don't miss any future episodes. In the meantime, hit me up on Instagram, Twitter, and TikTok at Kevin Brenner MD and KevinBrennerMD.com.